Hello, everyone, and welcome to our Military and Veteran Mental Health Virtual Continuing Education Series here at William James College. I'm Dr. Ginny D'Olympia, the Director of our Military and Veterans and Trained Vets to Treat Vets programs. And thank you so much for joining us again today. I now would like to hand this program over to our program organizer, Dr. Angela Tveda-Dick.
Hi, everyone. I'm Dr. Angela Tveda-Dick, and I'm one of the MVP faculty here at William James College. This is our last session in our series for the year, so we want to thank everyone for attending this session and others, and we're really excited to start planning next year's series. I'm here to introduce Zachary Ginsberg, who helped plan this session. He's a first-year clinical PsyD student who has a great interest in working with the military and veteran population. He has experience working with veterans through an internship and employment at Soldier On, Inc. And he is also our APA Division's 19 student representative. He has also been selected for the VA HP SP scholarship as well. Take it away, Zach.
Thank you very much, Dr. Tveda-Dick and Dr. D'Olympia, for putting on this fantastic training series and for the incredible work that you both do for active duty service members and veterans alike. It's my privilege to once again welcome today's speaker, Dr. Andrew Peckham. Dr. Peckham is a licensed clinical psychologist at the Bedford VA Medical Center and a research investigator in the VISN-1 Mental Illness Research, Education, and Clinical Center. As a VA Bedford Suicide Prevention Team member, he provides clinical care, consultation, and provider education about suicide risk to the community. In addition, he serves as the co-director of the Interprofessional Fellowship Program in Psychosocial Rehabilitation and Recovery. Dr. Peckham conducts research on emotional regulation, impulsivity, bipolar disorder, and has authored over 50 publications on these topics. He completed his doctoral training at the Clinical Science Program at the University of California, Berkeley, and his clinical internship at Harvard Medical School and McLean Hospital, and an NIMH-funded postdoctoral fellowship at McLean as well. Dr. Peckham, thank you so much for being with us today, and the floor is yours.
Thank you so much, Zach, and thank you everyone from William James for inviting me back for the last one of the year. Really happy to be here today. This is one of my favorite parts of my role on the suicide prevention team, is getting a chance to come out in the community and talk more about topics that are really relevant for working with veterans and also thinking about suicide prevention more broadly. So really appreciate the work of the committee and getting us to this point and doing all the work to set up this wonderful series. I'm going to go ahead and share some slides. And can everybody see that okay?
Yeah, it looks great. Yeah, it looks great.
Yes, so far so good. Wonderful. And thank you so much, Zach, for that really nice introduction. So before we get started, today's topic is going to be about suicide postvention. We'll say more about what that really means in a moment. Do want to note up front that much of this presentation, nearly all of it, is based on work supported in part by the Department of Veterans Affairs, but does not necessarily represent views of the VA or the US government. Today, we're going to be talking specifically about the prevalence and the impact of suicide loss, including common reactions to suicide loss, as well as most of what we'll describe, which is the unique role of us as providers, as suicide loss survivors. We'll talk about post-traumatic growth and healing after a suicide loss, as well as ways that we can support each other as providers, and particularly providers in many cases that work with veterans. Before we get going today, I do want to remind everyone that we are going to be talking about suicide here for the next hour, and this is really an intense topic. So if you do need to take a break, if you need to go off camera, if you need to step out, that is all okay. Really encourage everyone to take care of yourselves. If you do need to reach out and talk to someone, I also want to remind everyone that you can do that. And the National Suicide Prevention Lifeline is 988. Hopefully many of you or all of you know about this number. And if you are a service member or a veteran, you can dial that same number, 988. But then press 1 to connect with the Veterans Crisis Line. So I'm really happy to be back here today to talk more about suicide postvention, which I think is sort of the follow-up for any of you who are here for my original presentation a few months ago, where we talked about suicide prevention and ways that we can understand risk factors for veterans' suicide. Suicide postvention is the really important second half of this work. Before we get going on today's talk, and because we are talking so much about our role as providers in the suicide postvention and suicide loss process, I just wanted to give everyone a chance to reflect for a few moments and you don't have to put this in the chat or contribute anything, but just thinking about if you as a provider have lost a patient to suicide, thinking about that experience and what was helpful for you after that happened. Who was there for you? Who helped you process that professionally or personally? What could have been done that wasn't done? Are there things that you would have liked to have happen that didn't happen after that loss? If you are in the very fortunate position to have not lost a patient to suicide, I'd ask you to think a bit about if that were to happen tragically, what would you need? What types of resources would you want to be there to support you, again, professionally and personally? So we're going to talk about first the prevalence and the impact of suicide loss with that in mind. And I want to start out by talking about the definition that we use here within the VA about suicide postvention. So when we think about suicide postvention, this is a constellation of services. It's not just one thing that provide organized, immediate, and ongoing support following a suicide loss. So importantly, it is organized. There is a process. There's a team that goes into this that we'll talk about. And it is both immediately following a suicide loss and long-term. So it's a combination of immediate and ongoing steps. The goal of suicide postvention is to promote healing after a suicide loss. And by doing that, also reducing suicide risk for those who are impacted by suicide loss. So even though, like I mentioned before, today's talk is really about everything that might happen after a suicide, we see this as a very integral part of suicide prevention by responding to those who have lost someone to suicide. So thinking broadly about the impact of suicide, by some research metrics, we know that for every life that's lost to suicide, more than 130 people are exposed to that information. They learn about that death by suicide and are affected by it. So when you math that out and thinking about like the number of people who might be exposed to suicide in a given year, that means that more than 6 million people here in the US alone are exposed to a suicide loss with someone that they know personally. So thinking about everyone you might run into in your daily life, that means the odds are that many people you run into, even if they are not talking about this, have been exposed to suicide. And that includes our coworkers, our friends, our family, but also more incidental contacts, people we ride public transportation with, more distant relatives, classmates, things like that. So anyone you encounter may know someone who's died by suicide. So a suicide loss survivor can be defined in several different ways, and there's really two broad ways to think about who we would define as a suicide loss survivor. So most commonly, people think of a person who's lost a significant other or a loved one, a family member by suicide, and whose life has changed in some way because of the loss. But suicide loss survivors can also be anyone who experiences a high level of distress. Could be psychological, physical, and social, for some length of time after exposure to the suicide of another person. So this is what we mean by that network of more than 130 people impacted, that you may not have a strong personal relationship with someone and still could be affected by that person's suicide. You may not work directly with someone in our professional role, but still could be affected if they were to die by suicide. So we think about suicide loss survivors very broadly. It's also helpful in many ways to think about reactions to suicide loss within sort of the constellation of how we understand grief and how we understand the normative process of how people react to death and loss. So broadly, we know that when people experience grief and experience loss, there's a sense of universal bereavement that is really common across many grief reactions, including sorrow, yearning, and pain. Within this overall layer of grief, though, there are some deaths that are unexpected. And oftentimes when people are grieving an unexpected death, there's also a sense of shock or unreality that is within that universal experience of death. Within that circle, there's also the particularly painful experience of then having an unexpected or violent death that you learn about. And when a death is violent, there's often an added layer of trauma or a sense of invulnerability that's changed after that event. And then we understand suicide deaths to really be at the center of this. So in addition to all of these other layers of reactions to death, we often think about suicide as also having relatively unique reactions that might include anger, rejection, abandonment, or many other complicated emotions that we'll speak about in a moment. And that really highlights the point that when we're thinking about how to help with suicide postvention, we need to understand that suicide loss is different. and loss by suicide is different than other kinds of loss. So in addition to these more universal grief reactions, people may experience more pronounced post-traumatic symptoms to a suicide loss, including guilt or confusion, abandonment, shame, or anger. And suicide loss survivors themselves can also face stigma or even blame following a suicide loss. So for many reasons, this is a complicated form of bereavement that needs a specific type of intervention. So going a bit more into common reactions to suicide loss, we know that in addition to the more common emotional reactions following any loss, including sadness, anger, anxiety, loneliness, helplessness, or shock, people who experience a loss by suicide also often experience more complicated emotions such as guilt or worries about having not acted in the right way or not been nice enough to the person who's died by suicide, as well as really difficult emotions for some individuals, such as feelings of emancipation even, or relief. And these are often very painful or challenging emotions to process. People may also experience a lot of complicated physical reactions to experiencing a suicide loss. Many of these very similar to what we typically see in any type of loss that we described. So feeling tightness or hollowness, not feeling like yourself, shortness of breath, panic symptoms even, lack of energy or dry mouth. And then there's a lot of different types of thoughts, cognitive reactions, and problems with concentrating and focus that can come up following a suicide loss. So certainly, particularly in the early stages, there's often a lot of disbelief or confusion. And oftentimes after that, people can become preoccupied or really hyper-focused on trying to process, trying to understand this death by suicide. People may really become focused on thinking about what's in our own power or control, or underestimating how much other factors that are unknown to us may have played a role in a suicide loss. There's also the really important factor to reconcile here of hindsight bias. So again, for everyone here who probably knows what this is already, hindsight bias is this ability we have to somehow try to think that we should have known something earlier. It's the ability to evaluate actions taken previously, considering what we now know. And we often forget this when we're processing a loss. We often forget that there are advantages to hindsight that we simply could not have known in the moment. And we never have access to anyone's full experience and can't completely know how someone makes decisions to act on a suicidal thought. But this is really hard to remember and hard to feel, hard to believe when you're processing a suicide loss. Of course, there's also a number of behavioral reactions that someone might experience following a suicide loss. Many of these resemble symptoms of depression, sleep problems, appetite changes, withdrawal, pacing or overactivity, having dreams or intrusive thoughts about the person who was lost. And this can also look in many cases like trauma symptoms, such as avoiding reminders, places, or things of someone who was lost, searching or calling out for someone, or even visiting places or carrying objects that remind us of that person. And for each individual, this is likely to be different. For many people grappling with suicide loss, there's also this layer of existential and spiritual reactions that, again, are typical of many losses, but are often amplified for a suicide loss. So people, for example, may have changes in their self-esteem related to shame or guilt or difficult emotions about the person who was lost. This might intersect with someone's religious beliefs. For example, thinking about how could I let this higher power, how could I let my God let this happen? And there's a lot of painful emotions that can come from trying to reconcile your religious beliefs or spiritual beliefs with this event. Now, another thing to note that I think also comes up particularly when we're describing providers in suicide loss is this concept of cumulative loss. And essentially, cumulative loss is defined as the process that happens when a current loss dredges up feelings of past losses that one has experienced. And cumulative losses often are experienced as unexpected when we have a loss that provokes a reaction that we didn't quite expect it to provoke. So people would say things like, I don't know why I'm having this reaction. I don't know why I'm feeling this way. Don't know why I'm taking this so hard or why I'm crying or why I can't eat. And for many of us, experiencing a suicide loss professionally can also add to this layer of cumulative loss. And that brings up the next important part of this talk, which is really thinking about our role, all of our roles as suicide loss survivors, potentially as a provider. But before we move into this next section, are there any questions from the chat that are important to address, or any questions from the audience now that we should start?
There are currently no questions in the chat.
All right, thank you. So I'm going to play a short video that is developed by colleagues here at the Department of Veterans Affairs about how we as providers might respond to suicide loss.
You know, when you're standing at the base of a mountain that size, the peak looks like a speck in the sky.
He loved the outdoors.
But we made it to the top.
And his stories.
Just when a flurry of snow hit the air.
Unforgettable.
That was our second date.
But there was pain that he didn't share. How did I miss that? For someone I knew so well, why didn't he tell me? What could I have done better? It's his stories I can't stop thinking about. And I don't know who to talk to. I just keep asking myself, now what?
You're talking to me, and that's a great start.
As a provider, when someone you have worked with dies by suicide, it can be especially challenging to take in both the personal and professional impacts of this loss. You may find it hard to find ways to talk about the loss, and you may worry that bringing up your emotions and thoughts is wrong. Because a loss can impact your well-being, both in and outside of work, an important first step is to talk and reach out to trusted colleagues and supervisors. The provider section of Uniting for Suicide Postvention offers resources that can help you as you continue to navigate your loss. Please visit USPV today for support and to learn more about healing after suicide.
Does anyone want to share any reactions or thoughts to that video before we move on? All right, so moving ahead now in thinking about our role as providers, as potential suicide loss survivors, I just want to bring this back to what we talked about the first time I presented here a few months ago. If you're a provider who works with anyone in mental health, unfortunately, we have a heightened risk of encountering a veteran or a patient of any sort who might die by suicide. By some estimates, it's 1 in 5 psychologists or social workers who might lose a patient to suicide during their career. And unfortunately, this is a risk that is higher if you work with veterans. For all the data that I presented last time, we looked at trends, we looked at patterns over the past 20 years, and despite some recent decreases and improvements and reasons to be potentially optimistic in the rate of suicide going down among veterans, that rate is still drastically higher than civilians. So in many ways, this occupational hazard that we're thinking about here is going to be higher if you work with veterans in your career. And many therapists endorse a fear of losing a patient to suicide as among the greatest fears they have professionally. People who have lost a patient often identify it as one of the most profoundly disturbing events of their professional careers. And unfortunately, many clinicians experience a real sense of a professional void, an acute sense of aloneness and isolation after a suicide loss. And some providers, even who work closely with a veteran or a patient who dies by suicide, might even experience that loss similarly to the loss of a loved one who's died by suicide. So thinking about all of this together, we want to have tools, we want to have resources, we need to have a process in postvention that allows us to think strategically about how we might respond to suicide loss. So in thinking about our role as providers of suicide loss survivors, I think it's important to place this at the intersection of both personal and professional impact, meaning that we are going to have a personal grief reaction as human beings if we were to lose a patient to suicide, and we have professional impact, of course, on our identity as a clinician, on our relationships with other colleagues, and on how we even conduct clinical work in the future. It's normal to recognize this. So we walked through all of the ways that someone might respond to a suicide loss earlier. And certainly we as providers are not immune to that as human beings. But on top of that, we also may have some more complicated personal reactions such as self-doubt, self-blame, and fear of outside blame by our colleagues or by supervisors. Professionally, talking to many people who have been through a loss like this also describe a lot of potential impacts to your work as a clinician, including changes in how you consult with your peers, changes in how you might keep records, maybe potentially some changes in how you think about risk following a suicide loss. So for example, do you more quickly think about using involuntary hospitalization? Changes in how you approach clinical work more generally, such as changes in the population that you serve. People may also really fear that their privileges could be reduced. People might experience burnout, or may even leave the field entirely if they experience really an accumulation of losses or responses to a loss like this. This quote that I'm showing here, I think, describes really clearly what the process can be like, what the professional impact is like for providers who might lose a patient to suicide. There's often a phase of being really cautious and really hypervigilant early on following a suicide loss. So being very careful to maybe always think about suicide risk all the time, being hypervigilant about any sign of risk with veterans or patients that you work with. People may experience a lot of doubt related to a suicide loss and thinking, related to what I said earlier about hindsight bias, just not being sure about, can I trust my clinical judgment? Can I trust the instruments that I'm getting? Can I trust the information from the patient? Over time, for many people, this moderates and people are able to find their way back to having a sense of clinical judgment that feels less hypervigilant. But there is a normative process where from time to time, people still experience guilt or confusion or a lot of complicated emotions following a loss like this. It's also really important to place reactions to suicide losses providers in the context of ongoing stress more recently. 2023 is a different time in the world than it was maybe 10 years ago. The past few years have been particularly hard for healthcare workers for many, many reasons. And we've seen a huge increase in compassion fatigue and burnout, people leaving the field, cumulative grief. For many of us, hopefully the experience of cumulative grief is relatively rare, but not so much in the past couple of years with everything that's happened in healthcare. So I want to move next into thinking about the spectrum of what do we do? So thinking about how this is unfortunately such a high occupational hazard, I want to talk more about what postvention could look like. And there are a number of different ways to think about postvention strategies, but I'm just going to walk through several strategies that we practice here at the VA that we think of as being really helpful for responding to suicide loss. One of the first things we want to think about is how we remember someone who's lost to suicide and thinking about the content of memorials. And I think it's always important to remember that memorials should balance the need to reduce suicide risk for others and the need to allow survivors to grieve. So a general rule of thumb we think about is that we'd want to avoid any memorials or events that would not occur for individuals who died of other causes. Basically making sure to remember how someone lived rather than how they died. A rule of thumb I like to think about is that if we wouldn't create a specific memorial for someone who died of, say, heart disease or cancer, then maybe we shouldn't think about memorials in that way for someone who died by suicide. So really just trying to make sure that we are acknowledging suicide deaths through awareness, through talks like this, through prevention campaigns, but also creating memorials that really focus on someone's life rather than the act of suicide. It's also really important to exercise care and caution and data in terms of how we talk about a suicide death. So discussing suicide carefully and accurately can change perceptions and dispel myths, and also help to inform other people who learn about suicide about the complexities of the issue. So safe messaging broadly, when we think about safe messaging following a suicide, should be informative, should certainly be direct in terms of including the fact that someone did die by suicide, without being sensationalist though, without going into details that you may not need to include. It's really important to emphasize to suicide loss survivors that suicide is complicated with no single cause. It's important to place suicide in the context of also telling stories about hope and recovery and talking about all the resources that are available for hope and recovery. And then also providing access to resources that can help people through the grieving process. In terms of what this looks like in the workplace, so this could be the workplace for us as providers. It could be the workplace for people in the community who've experienced the loss of a coworker to suicide. You want to plan ahead. I think most importantly, having a plan for how you would respond to suicide before suicide occurs is a really important step to take. A postvention team, like I mentioned before, should provide both immediate support and longer term support. So thinking about what suicide loss survivors need immediately after a suicide, as well as what they might need 6 to 12 months later. You want the responses to be tailored to the unique needs of suicide loss survivors, a bit like we talked about before. And you also want to be sure to involve survivors of suicide loss in planning and implementing postvention efforts. So unfortunately, because of some of the ways that these unique reactions and responses can unfold, that does give people experience with understanding what these losses feel like and what is helpful and not helpful, sort of in line with my question I posed to you at the beginning. So having survivors of suicide loss involved in these postvention teams can be really important. So a postvention team essentially is a group of people who are already mobilized prior to a death by suicide. It's a multidisciplinary team of providers and individuals who work together to provide immediate and ongoing support to those impacted by a suicide loss. And importantly, the best practice for postvention teams is that it's not just one person, right? So it's not one person who is the postvention person at your facility or on your team, but it's a group of people that work together to make sure that there's a shared responsibility to do this work, because it is really hard. And the postvention team should be designed to be a source of comfort to those who are impacted, as well as thinking about a prevention team, ultimately, for reducing the risk of suicide further down the line. Many VA facilities have postvention teams that are embedded there. At Bedford, we've recently had a lot of discussions about how to improve ours and set up ours in various creative ways. And we've talked about who should be on a postvention team. So people like myself who are psychologists, social workers who are involved in suicide prevention, but also people from other teams around the hospital, folks from our chaplaincy program. Again, it's a lot of different people from different backgrounds coming together. But an important part of that, like I said, is to have clinician survivors be people who are both on your team and who are served by your team. So clinician survivors can benefit both personally and professionally from having these postvention protocols and teams in place to help balance administrative needs and emotional needs following a suicide loss. And for many people, for many clinician survivors, having these resources has been described as really reassuring and validating to that healing process, and also can help to prevent burnout. So broadly, after a suicide occurs, very early on, the suicide postvention team would be mobilized because we are notified about a suicide death. And then immediately following that, postvention teams can provide outreach to both providers who are affected by that suicide, as well as family members, people who are next of kin to that individual. In the short term, that can involve the next 1 to 6 months as being a time of offering some of these intensive services that I'll describe next, again, both for family members or for employees. But postvention teams also think about longer term impact, and that can include following up with providers, following up with employees and family members for, in some cases, more than a year or longer after a suicide death has occurred. Thinking about this idea that oftentimes reactions to grief are long and complicated and not just confined to this first 6-month period. So moving through these phases of what happens when you encounter a postvention team, we also want to emphasize for many people the possibility of post-traumatic growth and healing. So first, we take the step of helping people to recognize what their reactions are to suicide loss. And we really use a lot of the clinical skills that we'd use for anything else, which is to acknowledge and accept the feelings that come up as they come up after a suicide loss. And there is no right way to feel or wrong way to feel after a traumatic loss. We also encourage people to try not to take other people's stress reactions personally. People experience loss in many different ways, and other people on your team who are reacting to the same suicide loss may have very different reactions than your own. We also really encourage people who are affected by suicide loss to talk about it, to talk about their feelings and reactions, either with coworkers or with friends. We encourage people to accept help from others, despite any discomfort that comes up around showing your own vulnerability. We often don't think about showing sort of personal vulnerability at work in this way. And that's really why postvention teams exist, to make sure that there is a place to talk about how these issues are coming up and affecting our work. Should mention as well that we also have our EAP, Employee Assistance Program, involved in this too. We also want to encourage people to connect regularly with other people outside of this circle of colleagues and coworkers, anyone that would provide them support during any traumatic loss. And then, of course, we really encourage self-care. So we want people to think about what they need during times of high stress, whether that's maintaining a routine at work for some people or taking time off for others. We really encourage people to focus on the basics around physical self-care, around exercise and eating and sleep. We encourage people to avoid making major life-changing decisions unrelated to the events, while also just trying to maintain connections with people who are helpful. This is advice that I'm sure many of us would probably give to many of our patients and many of our coworkers through any loss. But I think it's also really important to keep in mind that as providers, this information is also still really important for us to take to heart. So we encourage people to take care of themselves during the day. So whether that's taking time aside to take deep breaths, to meditate, to actually take a lunch break, to end the workday on time, and to really try to unplug at the end of the day, particularly during this time following a suicide loss. If necessary, we really encourage people to ask for help from mentors, from supervisors, from colleagues that they trust, being encouraged to say no and to set boundaries when that's appropriate, and also being open to the idea of seeking therapy services ourselves if we're having reactions that are appropriate to therapy and that could use that added level of support. Through all of this, some of the really important concepts that we talk about in postvention is, again, reminding ourselves as providers and reminding other survivors that suicide is complicated. It is almost never the result of just one thing, and usually involves a set of really complicated factors that raise someone's suicide risk to a particular point. Again, I want to talk about hindsight. And this is something that often intellectually makes sense to us until it happens to us with a suicide loss. But there is no way that we could have known that a suicide would happen on a particular day at that precise moment. And it's really hard to understand that as you're going through a suicide loss. It's also really important to keep in mind the idea of ambivalence and not knowing. So this is really something that many suicide loss survivors wrestle with for a long time, of just not quite knowing what led up specifically to a suicidal action. And that is really normal, to wrestle with that ambivalence and to just not quite be sure. Through all of this, though, it's really important to also remind suicide loss survivors to work in, as much as we can, thoughts about people's lives rather than just the act of their suicide, thinking about other aspects of their lives, of their journey, and using that to think about how to move through this post-traumatic growth process. So post-traumatic growth is defined as any positive change that's experienced as a result of any kind of highly challenging or highly stressful experience. So when we think about post-traumatic growth, as many of you probably already know, we think about outcomes such as a greater appreciation of things in life, improved relationships, maybe personal or spiritual change happening after a traumatic event. And suicide loss, like any other traumatic event, can also involve some aspect of post-traumatic growth over time. So for us as providers, with this balance of having optimal support, for some people, there is a long-term personal and professional transformation that can include new questions about who they are as a person or as a provider that after this initial loss may not all be negative. It could include increased gratitude or a sense of need to give back to others. It can also include new professional growth, including knowledge about suicide and knowledge about how to respond to suicide loss. Or maybe even thinking more broadly about our own limitations of what we can control or not control in our role as providers. And again, this is different for everyone. As you go through this process, though, we also really emphasize that healing takes time. This is not a set timeline for everyone, and it is different for everyone who experiences a suicide loss. And setbacks, or what can feel like setbacks, can occur well after a suicide loss and can really catch people off guard. So if we're either thinking about our role as providers, or we're thinking about family members or friends or anyone impacted by a suicide loss, that's why we want to make sure that we check in on people slightly longer term to remind people that it is normal to have reminders that come up that can be unsettling or upsetting long after a suicide loss. Which brings us to the last point about the importance of supporting each other as colleagues and providers. So much of this, I think, is common sense, but I think it is really important on these provider-focused suicide postvention teams to be willing to be open and have tough conversations and to keep checking in with providers, even if they might say, I'm really doing fine, being willing to come back and check in a little bit later just to make sure that someone isn't ready to talk on a certain day doesn't mean they might not be ready to talk a couple of days later. Being willing to just listen and give them your full attention. And also just trying to understand someone's choices and emotions from their point of view rather than our own. And this can be particularly hard when you have a lot of people on a team, say a team of providers who all experience the same suicide loss. Again, getting back to the idea that we're all going to experience it in different ways, it is really important to have that patience to let people have reactions in their own specific way. It is important also to validate and to focus a lot of these conversations on reflecting and thinking and processing together rather than jumping to problem solving, reframing, or advising. There is a process for that is separate than postvention when we think about improving suicide risk measures, but postvention is really about making sure that we are focusing on survivors themselves. And then finally, being able to offer support. So being able to ask what a suicide loss survivor needs and helping to assist them with specific, tangible supportive tasks, checking in on potentially important events like holidays or loss anniversaries, or even other events that might not be directly related, such as Suicide Prevention Month in September, when a lot of media coverage is focused on suicides. And also being willing to think creatively on your teams about how to honor someone who's lost to suicide. So thinking together about what are ways that we can memorialize this person as a team or talk about stories about their life. So this could include, for example, having an informal celebration of a person's life, sharing a meal together, talking together about who that person was over time. Other people may step into more advocacy-focused roles, so supporting suicide prevention teams or joining a postvention team in the future. But I think ultimately what this comes down to is being willing to check on your coworkers over time and continuing to have these conversations pretty long after one of these events has occurred. So lastly, I just want to talk about some resources that are so helpful, and I'll make sure that we provide PDFs of certainly these resource pages at the end so you have all of this. Most of what I've shared today is publicly available on the suicide postvention websites operated by the VA. So I want to give credit to, you see down there on the lower right corner, the Rocky Mountain MyRec Mental Illness Research Education and Clinical Center has developed a whole library of resources. If you're interested in learning more about setting up a postvention team or learning about how to provide information to others, this information is there. So on this website, there's a number of other short video clips. There are a number of PDFs and downloadable information you can use to think about in your clinical practice. There's also podcasts and information that are geared more towards community members or people at the workplace. Most of what we really focused on today, of course, is on us as providers, but there is a lot of other information for other community members as well. And all of this is publicly available. This is just an example of some of the different things that you see there. So you can download articles, slides, other presentations, information about other resources, other organizations that are available. There's a number of veteran service organizations that provide support to family members of veterans who die by suicide. So one of those organizations I mentioned last time is called TAPS, and they provide a lot of really wonderful resources to the spouses and children and other family members of veterans who die by suicide. So lots more information that you can find online. The other thing I want to call your attention to is the Suicide Risk Management Consultation Program, which provides free consultation to any provider in the community or within the VA who serve veterans at risk for suicide. So I really like their motto, which is to never worry alone. And I think we really take that to heart, is that if you're worried about a veteran who you're working with, there are a number of different resources for you. And these are operated by, like I said, this particular MyRec within the VA, but are also available to community members who serve people who are veterans. So this includes information about how to conduct risk assessments, information about how to conduct lethal means counseling, which we talked a bit about last time, best practices for documentation, thinking specifically about how to engage veterans at high risk, as well as a lot more information about postvention, like we're talking about today. So really highly recommend this information on this website. And here's just another example of the types of things that are there. So again, videos, lectures, lots of information. So with that, I just want to pause and make sure that we leave plenty of time for questions or reflections or anything else. But thank you all for listening. And thank you again to the William James team for putting this together today.
Thanks for that incredibly touching presentation for us. I'm looking through. I don't see questions currently in the chat, but hopefully some folks will have some questions that they can add. Anybody have any questions? Sometimes it's like this in my class. It's very quiet. That's okay. I think what do you think would be the maybe the most important takeaway that people should go home with here?
So I think, can I give you two?
Absolutely, yes.
So I think number one is that postvention is a form of suicide prevention. So how we respond after a suicide is also how we prevent suicide. So I really think of it as being a catch-22, is that we know that suicide has such an impact on people, and it's such a hard thing to think about and talk about, that it really, really, really is important to think about how we respond to suicide as a way for preventing future suicides. We know that one of the biggest risk factors for acting on suicidal thoughts is having a close family member die by suicide. So I think knowing that there are responses to suicide loss that are really helpful for dealing with that trauma is just so important to know. So this is suicide prevention, even though we are calling it postvention here, would be point number one. And I think point number two is that, like, you know, in a lot of our professional roles, my takeaway is that there's often a lot of pressure to sort of just like move on and to not talk about things that are hard and to get back to work. And we have a lot of busy things in all of our jobs, I'm sure, that really push us back towards that impulse of not talking about painful things and getting back to work, even though we would never really encourage that of our patients. So I think reminding ourselves that, like, it is really important to talk about this, and it is important to take time to process it. If this happens to you, it's really important.
Thank you. I think those are really good. Those are awesome points to make. I think one of the hardest things as a clinician, and even as a professor, is remembering to tell people that first point that you made, which is that it can be easy to sensationalize this experience because there are so many emotions and unresolved grief wrapped around death by suicide. So taking a few steps back, talking to people and trying to maintain the balance while grieving the person and not, sensationalizing the loss, connecting that to the intense grief and sadness around that can be really
Absolutely.
And it looks like somebody has a question. It seems like that might be, I'm not sure. I'm going to ask it just so that you can be aware that question is there. I think it's a pretty intense question. Have any providers experienced death by suicide of a client, how they deal with that? I wonder if it might be easier to ask if people had some ideas that work well for them or in their community where they sought assistance after or that they might suggest for other clinicians in their areas, aside from the ideas that Dr. Peckham has discussed here today. Okay, so somebody shared in the chat that they lost a client and it was really hard to move through it. And everything, it was definitely a journey to move through everything it brought up. And thankfully I felt supported by my supervisor, boss, and team at the time. Those are really great things as reminders too. Because you talked about that, Dr. Peckham, as seeking assistance with your team, because your team really can be the glue that holds you together in that really difficult time.
Yeah, absolutely. And if you don't have a team, I guess the other thing I want to mention is that you may be someone who doesn't quite work as much in a team setting as we do at VA or in other hospitals or places like that. So if you're someone who's in private practice maybe, and you are in a very small team, or you don't have much of a team around you, I really think about professionally, like, who else do you consult with on difficult topics? So is it someone that is another clinician who's also bound by the same confidentiality guidelines as you are, who is part of a consultation group that you can join? Are there other professionals you can talk to within your professional circle about some of these issues? So I think one of the really challenging parts of this is that we often process really hard things with our family members, our friends, our spouses, things like that. And it's really hard to do that ethically when we're thinking about also protecting the confidentiality of someone who did die by suicide. So it prevents us actually from having a lot of conversations in any kind of detail with people who are part of our personal support network. So that's really where us as colleagues comes in, right? So having a team of people around you who can talk to you about like what it is like to be a provider going through this professionally is so important.
Here we have another thing, a couple other things mentioned in the chat. The piece about really managing how much control you imagine that you have over people is very important. Definitely would agree with that. I definitely have spoken to folks before who've said, if you ever read in the paper, you know, that I died by suicide, it's not up to you. It's up to me. I get to decide what I do with my life. I would definitely agree with that. And there's another person who wrote, not from a client, but a brother-in-law, and it was complex due to being a mental health clinician. I definitely experienced some of the cognitive distortions like retroactive thinking. Taking time for myself to reflect and be kind to myself was helpful. Understanding that being a therapist is not being a mind reader. We can't stop clients or people from hurting themselves. We just give them the tools and supports to make sure they have the choice to live.
And that, I think, it's a really good point, because so much of the time when we focus on suicide prevention efforts, we are really teaching people about what we know from the data, which is that suicide is preventable. And so much of what we talked about at our last time I was here was about how do we think about effective suicide prevention, and how do we do lethal means counseling, and how do we reduce suicide risk. However, suicide being preventable does not negate the same fact that this person's bringing up in the chat, that we can't read people's minds. Suicide may be preventable, but we don't know what someone is thinking. We don't know what someone's feeling. We rely on people to tell us about these things a lot of the time. And it's often, you know, very easy to go into that hindsight bias mode and think, of course we should have known this, of course we should have picked up on this, where realistically, we can't know everything. And as much as you can do really good risk assessment and think about suicide prevention in all the ways we'd encourage, we can't know everything as providers. So being able to process that and think about what we do with that if we are in the position of experiencing a suicide loss is such an important part about being able to move forward.
Here's another one that asks for your thoughts. This person has said they had a client die from a cocaine overdose, and they questioned that it might have been suicide because they thought the addict knew better about how much to use, and they're wondering if you have any thoughts about that specifically.
Yeah, no, I unfortunately that's I'm glad you brought that up, because so much of the time when there is overdose or substance use involved in suicide attempts or suicide deaths, there is a lot of uncertainty about someone's intent. And there's a lot of unanswered questions sometimes about when someone has had an overdose death, how much there was suicidal intent and how much it was an accidental overdose. And I think, unfortunately, even if you may have an inkling one way or another about like what you think someone's intent was, we still don't know. And it still gets back to this problem of not knowing in the moment what someone's intentions were. And it's so hard to sit with that, right? Because we may really want an answer about like, was this an accidental overdose, or was this person really intentionally trying to kill themselves? And we can't know that. So I think that's just like a really hard thing to sit with, particularly in people with substance use disorders, when that is part of all of this as well.
That's a great point. I think that can happen in many different instances of accident.
Absolutely. Yeah.
Great. Well, I don't see any other action here in the chat. Many people have said thank you for the work that you're doing with veterans. It's deeply appreciated. Many people said thank you, that this is very informative and powerful, and that they appreciate that you've taken your time to join us here and share this information with the community. And I want to second that. We definitely appreciate the work that you put into these presentations, the work that you're doing in the community, and the connections that you're making to prevent as many deaths by suicide as possible.
Thank you. I'm really happy to be here, even though this is always such a hard topic to talk about. I'm really grateful for the chance to be able to have the conversation, and also trying to normalize that this is such a hard thing for us, and it's okay and good to talk about it. So really appreciate all of you being here today and being willing to learn about this and think about it, and offer all these thoughtful ideas and comments in the chat too. And again, happy to share some of these resources so you can make sure to get all this information and find it where it is online.
Great, thanks so much. We'll be having another series again next year. As Dr. Tvedic said, we're really excited about offering this again. This series again, we're starting our planning now. In the meantime, we will be offering monthly monthly training about safer storage and lethal means as a means of safer storage of lethal means as a prevention method for death by suicide, especially with our military and veteran population. So we hope you'll be able to join us for future trainings. Thanks for the work that you all do, and thanks for attending. We couldn't do these trainings without you.
Thank you, everyone.